Lumbar disc herniations. The lumbar spine is composed of 5 vertebral bodies, and they're separated from each other by a disc. At each disc level, a nerve exits the spine, and all of these nerves join in the buttock to form a larger nerve known as the sciatic nerve. The discs are composed of a strong annulus on the outside, which is collagen type 1 fibers, and they're very strong in tensile strength, so they keep the spine from being pulled apart. The inside of the disc is known as the nucleus pulposus. It is a hydrated gel that is very strong in compressibility. If a disc is injured, it's usually in torsion. Discs are weak in twisting. Therefore, it is not lifting the bag of cement that injures the disc, but putting the bag down, twisting. When you lift, you should always remember to lift by keeping your shoulders and your pelvis in the same plane. It's that twisting under weight that tends to injure lumbar discs. Discs are named according to the bones that they are between. So, for example, between the L4 and the L5 vertebral body, you have the L4-5 disc, and the bottom disc is known as the L5-S1 disc because of S1 sacrum. 95% of all disc herniations occur at L4-5 and L5-S1, with L5-S1 being the most common level to herniate. The most common age is in the 4th or 5th decade of life, and disc herniations are 3 times more common in males than females. We classify disc herniations according to where they occur on the disc. 90 to 95% of all symptomatic disc herniations occur paracentrally. At this point, they will catch the nerve root as it's just about to exit the foramen, and it produces pain in the back, buttock, and down the leg known as sciatica. The central disc herniation many times will just damage the annulus, causing back pain, but does not pinch the nerves enough to cause sciatica. A far lateral disc herniation is when the disc herniates outside the foramen, outside the spinal canal. Just outside the canal, the nerve expands with a ganglion, and if the disc herniation pinches that ganglion, those disc herniations are much more painful or more severe. We also classify disc herniations according to their anatomy. It is possible for the nucleus pulposus to bulge out, causing a swelling or protrusion in the annulus, but it does not tear the annulus. This is called a disc bulge. If the herniation tears the annulus, that is called an extrusion. If the extruded material after breaking the annulus breaks free, that is called a sequestered disc fragment. Symptoms of a disc herniation: number 1, the tear of the annulus fibrosus, which is full of nerve fibers. If you tear the annulus, you can have severe lower back pain. That is called discogenic pain or mechanical lower back pain. If the nuclear material begins to impinge upon the spinal cord or nerves, that can cause pain radiating down the lower extremity, classically into the butt and down the leg. It tends to be worse with sitting, improves with standing, and symptoms also worsen with coughing and sneezing. Each specific disc in the lower back, because it is associated with a specific nerve, carries with it a unique set of symptoms. So, for example, a herniated disc at L2-3 would catch the L3 nerve, and that can cause pain radiating into the front of the thigh, and it causes weakness to the adductor muscles of the hips, or the muscles that pull your hips in. The L3-4 disc herniation can get the L4 nerve. That supplies the quadriceps, so you have weakness in extending the knee, and you may be missing the patellar reflex. A L4-5 disc gets the L5 nerve. That goes to sensation on the top of the foot, can cause weakness to pulling the foot up, or a drop foot if it's severe enough. It goes to the EHL that pulls up the big toe, and it is the abductor muscles of the hip, so you can't pull your hip out. Or in extreme conditions, you may have weakness of the gluteus medius muscle and develop a Trendelenburg gait. And that is where the weak side can't hold up the strong side when you walk. So you tend to drop the hip on the strong side when you try to walk. That's a Trendelenburg gait. The most common disc herniation is at L5-S1. L5-S1 disc herniations get the S1 nerve, and that goes to plantar flex the foot, or to stand on your tippy toes, and you lose the Achilles reflex. In rare instances, a very large disc herniation can close off the spinal enough that it can cause what's known as Cotta-Aquinas syndrome. Cotta-Aquinas syndrome is associated with weakness, numbness, tingling in both legs, saddle anesthesia, and bowel and bladder symptoms, loss of bowel and bladder habits. A provocative test that's done by the physician to evaluate for a lumbar disc herniation is the straight leg raise test. With the patient laying on their back, the surgeon will raise the leg, and that puts tension on the nerves in the lower back. It's good for testing for the L5 and the S1 nerve. Also, if the patient has that, it's a positive indication that the patient will do well with surgery if it comes to that. The first imaging technique that is used in most individuals with lower back pain is the X-ray. With the X-ray, we can see degenerative changes, we may see some loss of disc height, but it basically just shows bone. The study of choice, or the modality of choice to evaluate a lumbar disc herniation, is an MRI scan. An MRI scan is a magnetic picture of the lower back that shows us the anatomy of the lumbar spine. Now, with MRI scans, there is a high rate of abnormal findings even in normal asymptomatic individuals. So if your MRI scan shows you have a herniated disc, but you have no symptoms, you don't need surgery. What are the indications for obtaining an MRI? If you have had pain that has been present for longer than 1 month and has not responded to conservative management, then an MRI should be considered. In some cases, the surgeon may request that you get a MRI scan with contrast, which is known as gadolinium. That is typically done if you've had previous surgery. The gadolinium allows the surgeon to look through the scar tissue to evaluate for a recurrent disc herniation in somebody who has had previous surgery. Treatment for a disc herniation is divided into non-operative and operative treatment. As far as non-operative treatment of a disc herniation, it's important to keep in mind that the natural history of a disc herniation is to get smaller with time. Disc herniations tend to get reabsorbed by the body, and just because you have a disc herniation does not mean you have to have surgery. 90% of patients who have a symptomatic disc herniation will see significant improvement in 3 months. First line of conservative treatment may be bed rest if it is severe enough, or at least some rest. Then we use medications such as nonsteroidal anti-inflammatory medications, ibuprofen, muscle relaxants, and even oral steroid medications in a tapered dose can be effective. Physical therapy, especially with extension exercises, has been shown to be extremely beneficial. Traction devices work, chiropractic manipulation have all shown to be very successful in treating lumbar disc herniations. If that first line of defense does not work, then we go to the second line of treatment, which is pain management, to include various injections such as epidural injections and selective nerve root blocks. Selective nerve root blocks and even epidural injections work better for leg pain than back pain. If an individual has a herniated disc with a large amount of leg pain, the epidural injections will be more successful. The indications to undergo surgery. Number 1, persistent severe pain that has lasted longer than 6 weeks and has failed all those non-operative treatment options that we discussed. Number 2, if you have progressive and significant weakness, you may need surgery. Number 3, obviously, if you have Cauda equina syndrome, you probably need surgery. Surgery is a laminectomy and discectomy. A laminectomy is where some of the bone from the bony spinal canal is removed so that the disc can be removed. Removal of the disc is called a discectomy. Center, we use minimally invasive techniques. We either do a microdiscectomy or an endoscopic discectomy. These procedures are typically outpatient procedures, back to normal activity within a few days, high-intensity activities in 4 to 6 weeks. The best indicator that you will do well with surgery is how well your symptoms correlate with what is seen on the MRI. Then the outcome with that type of surgery is excellent, with significant improvement in the quality of life, function, less pain. I hope you found this video informative. Thank you for watching. Tell your friends and neighbors to watch. Give us a thumbs up and subscribe. If you have any questions, write to me at Dr. Smith, ElPasoSpineCenter.com. Thank you.